Okay, ladies and the gentlemen, we're going to do our first video. And I thought that we would start with, well, first of all, welcome. And for those that don't use YouTube very often, hopefully it was not too much trouble. If not, just send me an email and I'll explain to you a little bit how it works and stuff. So we'll start with the... I thought that, because I'm still waiting for some books to come to start studying and things like that, but I thought that after I did my CLS course, I saw some things that I was like, so we're going to start talking about airway, breathing, and circulation, so the ABC, but in a way that I don't think one of you guys heard before. So we're going to start with the airway, and we're going to talk about airway management, and for that I would refer you to a link that I sent of the mnemonics to remember. A lot of problem that I see in right now is the airway means tubes, and it's not. So airway is not equal a tube. It means airway management. There's different ways of hearing. There's different ways of managing the airway that you don't need to tube the patient. Tubing a patient means that you need to have the skills for doing it, and also means that you need to have the staff for doing it, because it is an intensive thing, especially if you're going with the rapid sequence intubation. You need drugs, you need people to prepare the drugs, you need the people to administer the drugs, you need to know when you're going to administer the drugs and everything. And it takes time, because you need to go, draw those drugs, yes, prepare everything ready and stuff. And if you don't do it very often, which is kind of our situation, then it becomes longer and longer to do. So airway doesn't equal a tube. So we're going to start right there on that note. So then what else can we do? Well, there's kind of 4 different ways of holding a tube to maintain an airway. And again, we're talking about somebody that cannot maintain their own airway. So we have to maintain them for them. Because if they can't maintain their airway, then it's kind of a moot point here. Because we're not talking about airway management, they're maintaining their own airway. So the first one, like everybody knows, is the endotracheal tube. And in your little sheet there, it's the lemon. So the mnemonic of lemon is basically attached to this one. The second way that we can have is laryngeal mask, or supraglottic. Well, let's call that supraglottic device. I like that this way better, because the ones that we always talk about is LMA, and maybe it's not the best one that we can use anyway. The third one would be the good old bag mask. And this is one that you can maintain the airway. Obviously, you cannot do it for hours and hours and hours, but you can maintain an airway for that. And the fourth one is the one I hope no one ever goes to, but you may have to, which is a surgical. Let's go with surgical airway, and we'll talk a little bit more about it. So those are the 4 different ways that you can have. And in your sheet there's how to assess every of them. And it's very important, and this is what I'm going to talk about. So if you go to a patient, always assess those 4 ways. And I'll just write numbers now, but 2, 3, and 4. And why is it important to check those 4? Because it will tell you which where to go from there. Like what should we do here? And here we'll give another example. Let's see if pull that up a little bit more. There we go. 3 and 4. So let's say we have person A and person B. Person A comes and you do your assessment. So again, look at the mnemonics and they'll tell you a little bit and stuff. So you're doing your mnemonic and you're looking at the AT tube. Yes, I could intubate very easily. My laryngeal airway, yes. Subarachnoid device I could use, yes. This person would be easy to bag and everything wouldn't be any complication and no complication for Craig. This is near the airway. So basically you can almost take more chance because if this one failed, I got 3 other ways that I can back it up. Let's take person B. Not a good airway to do. Pretty decent supraglottic device. And bag mass, he's got a big beard and he's kind of, he's kind of a fat person with a short neck. So not so good for intubation. Big beard, seal would be difficult. And Crike, well, I can find his neck, but I probably could do it. Different setup here, and that's why my approach will be different as well. Here, RSI, probably yes. Here, RSI, probably no. Why? Because if you don't take something that you cannot give to this person. If I cannot bag this person properly, and I cannot put an LMA, so for whatever reason, something that I didn't foresee, because obviously those evaluation is to tell you, yeah, they're probably in a good category or they're not in a good category, but now that means that this person, the only thing that you can do is a crack, and you're not even sure of that. So you're a little bit more like, whoa, okay, let's slow down. So probably RSI you wouldn't be using it. So this is why when you do airway management, it's not just about having the drugs and putting tubes and stuff in people. It's assessing all the tricks that you can have. A subarachnoid device can be an airway, and it can be used properly if you use the proper thing, and no matter what people say and stuff. And I mean, especially in the setting that we are, where we're transferring and we're 5 minutes from a big hospital. Why would I? So if I'm 5 minutes. So this is the new kind of philosophy of EMS. So if I'm 5 minutes from a hospital and my RSI takes me 15 minutes, why would I RSI? I'm 5 minutes. I'll put a supraglottic and move on. It's 5 minutes, so I could put a device in it and kind of, like if it takes me 15 minutes to look for my tube, look and put the stuff and everything, so then I can just drive for 5 minutes. Well, now let's replace EMS with a center like ours. Why would I spend 15 minutes trying to put a tube into someone and stuff like this when in 5 minutes there will be way more people, way more personnel and everything. So this can be part of your airway management as well. And I'll link an article down. So when you say I link stuff, is that if you look down the video, you'll see a blue link, and if you click on it, it will link you on a place to go on the internet. So now that we approach this, so now I need to know what I'm going to do and stuff. There's other stuff that we can do before whatever tube that we decided to go. So if it's a crike, we're not talking about crike. Crike is a no-no, and pretty much like, unless you're in the OR or whatever, no crike. We're talking about crike, which is quite different. Subarachnoid tube, there is a limitation, but there is their use. And a lot of people, for example, the subarachnoid gets bad publicity because they say, oh, I cannot prevent the content of the stomach, and it doesn't protect the airway very well. Well, there's a lot of them, and the ones that for example, EMS uses the King LT, and the King LT is something else. You could put an NG tube, OG at that point. You can put an OG tube right behind it. So as you put your device, there's another space. You put an NG tube, and now you suction the content of the stomach. So I don't see why something that's going to take me 2 or 3 minutes to basically, that's pretty much almost like, I mean, let's say 5, and then put an NG tube, suction the stomach, versus having to try to figure out a procedure that's been years that I didn't do that people are not comfortable with will take probably 20 or twice or 3 times the time, when the other person could be having their airway managed. So it's airway management. It doesn't mean a tube. So that's why they're really important. Other tricks that we can do to help with the airway part of things is, and it's one of the very easy tricks, oxygen, and we'll talk a little bit more about that in the second video where we're going to talk about breathing, but oxygen goes by diffusion. That means that by concentrations of greater concentration I have will go into my alveoli. I don't need to breathe to have oxygen. It's just by a diffusion process. If I have something that blocks my diffusion, so if I have fluids or if I have gunks like for pneumonia or an inflammatory process or RDS, then my diffusion will be harder to go, but I still can bring the oxygen in. It will be, but unless I have this, the fusion will happen there. So easy trick to do is basically put nasal prong in the person. So, but instead of putting it how we used to put it, you just put it towards the back. And instead of the 5 liter that we put it, we bump it up a little bit more. So basically now the person doesn't have to have a saturation that's going to go down, because you can provide them oxygen even if you're going to put a tube and everything. So that's a quick trick that you can have. Also, knowing the different drugs, because different drugs have different reason of it, and I don't want to get into that debate because each doctor has their own things. But one thing that I'd like to bring to your memory, to your mind, is that a lot of the drugs that we use for rapid sequence intubation also decrease the blood pressure. So if you look at things like morphine, fentanyl, midazolam, yes, they can be used in the RSI, but that means also my blood pressure will go down. So be aware of that. The drugs that you're going to use will lower your blood pressure. And we seem to sometimes forget about that. We're giving all those drugs, but they lower blood pressure. And in someone, for example, with a head injury, each episode actually, let's put it that way, each episode of lower blood pressure or decreased oxygenation, so decreased oxygenation or hypotension, each episode increase the mortality of something by like 10%. So each episode, so if I have 3 episodes, that's 30% increase in my obviously it's very bad stuff for head injury, so you don't want to have this. So if you're suspecting a patient with this, then it becomes a little bit different. SAT, we'll talk a little bit more about it, but don't have it just like as a the SAT. There's other stuff that you can use to tell you about your status on your breathing. So use more so your skills and your airway and stuff. When you use the bag, also don't recommend to have the one person, because it doesn't work. It's hard to put a seal. So 2 person. If you're gonna bag someone, go 2 person. Go with the head, hold the head, maintain the airway up, and then let the other person bag. Anybody can bag. A security guard can bag. A janitor can bag. Everybody can bag. All they have to do is squeeze a bag, and you let them know how to squeeze. Maintain the airway, so that means prong, and you can also go with 2 nasal prong and OPA, and then you can hold the airway and stuff. That would be more in bed 4, but really important to go with 2 hands. And I'll put another video of another link on the reason why I recommend this and stuff. So now we have put the tube, so we're trying to maintain our airway. We have decided, we did an approach. That's why I will refer you to like those mnemonics. But one thing also, don't forget, once you have this tube, and next thing you brush your teeth, just put your toothbrush in the back of your throat and try to, keep it there for hours and hours, and you'll see how it's impossible. So sedation. But again, doesn't mean that you need to lower the blood pressure. There's other stuff that you can give. There's tons of other products that you can use for blood pressure that to create the sedation that don't use blood pressure, or that are sometimes better to some patient than some others. So be cognizant of the drugs that you're going to use, and be cognizant of that. If the blood pressure is lower, the blood pressure is bad for this patient, there's some drugs that you don't want to use, and you can use some other drugs and stuff. So hopefully that was helpful, and we'll go to B on the next one.